Well, the first thing I think we need to fix is we need to stop whining as doctors. We need to stop complaining. We really do.
Goodness.
There's so many things that are wrong. Part of it, it's our fault because we just let it go and we let it happen because we were busy taking care of our patients and we let other people start to manage healthcare.
Paging Dr. Cook. Paging Dr. Cook. Dr. Cook, you're wanted in the OR. Dr. Cook, you're wanted in the OR.
Welcome to the Prescription for Success podcast with your host, Dr. Randy Cook.
Hello, everyone, and welcome to Prescription for Success. I'm Dr. Randy Cook, your host for the podcast, which is a production of MD Coaches, providing leadership and executive coaching for physicians by physicians. To overcome burnout, transition your career, develop as a leader, or whatever your goal might be, visit MD Coaches on the web at mymdcoaches.com, because you're not in this alone. Well, it's holiday time, and for the next couple of weeks, we thought it would be nice to look back and hear some highlights from some of our favorite Season 3 interviews. In today's show, we have short clips from 5 episodes from the 2021 season. We'll begin with episode number 55, Christopher Sheeran. You know, even though most of our guests are physicians, from time to time, we really like to feature non-physicians who work in areas that have a big impact on physicians and other healthcare professionals. Chris is just such a person. He is a powerful advocate for all physicians as well as for the healthcare system in general. As the CEO of Grayson & Company, based in Washington, D.C., he is very much involved in the ongoing conversation about healthcare economics. So here's a little bit of that conversation. I really want to hear, and I think our audience wants to hear, all of the details about the beginning and the mission and the success of Action for Health.
Absolutely, Randy. And we could probably do 10 of these sessions and not only scratch the surface on this issue in particular. I began working on the issue of surprise medical bills back in the summer of 2019. And then fast forward to February of last year, I founded and launched Action for Health. We're a nonprofit patient advocacy organization that's dedicated to working on this issue of surprise medical bills. We like to say surprise medical bills because so many in the media, Randy, say surprise medical billing. That is not accurate. The activity of billing should surprise nobody. Physicians send their bill for their services rendered.
Yeah, that's a great point.
The surprise comes from the actual bill that they receive from this out-of-network provider, but we could, of course, dive into that. So for the past 2 years, we've been very focused on this issue. As your listeners will know, it was probably the most hotly contested healthcare issue up on Capitol Hill for the past 1 to 2 years. That and pharmaceutical pricing as well.
Well, you know, I think a lot of physicians are going to be a little surprised to hear that, because for those of us who are actually delivering healthcare, and I have to interject here that doesn't actually include me anymore because I am retired. But from my perspective, and from the perspective of most of my colleagues, it seemed like our patients were getting that surprise little notice in the mail again and again and again and again, and everybody knew that it was unfair, but it didn't seem to us that anybody was taking any interest at all. But it sounds like clearly you were. There has been a good bit of conversation in Washington. I have to tell you that, frankly, I'm a little surprised to hear that. So tell us more.
Certainly, Randy. So this goes back, all the way back to the passage of the Affordable Care Act back in March of 2010. Mm-hmm. The ACA had the chance to fix this issue of surprise medical bills. They intended to do so. However, once regulators got a hold of the issue after the law was enacted, they basically gave health insurance plans a way out, saying that they had to pay the greater of 3 amount. The AMA actually warned that this would lead to a drop in the contracted rate and also lead to more surprise medical bills. And that's exactly what happened. So after much debate on Capitol Hill, many stakeholders weighing in, multiple competing proposals within up to 5 committees of jurisdiction in Washington, both on the House and on the U.S. Senate side as well, we finally had a quote unquote solution that was, I'm going to say, snuck into last year's omnibus spending bill. So now patients are out of the middle. Patients will be held harmless. And starting January 1st of 2022, it will be illegal for a provider to submit a bill to patients for their out-of-network services for a greater amount than what that in-network rate would be.
So I guess my next question is going to be, is it really going to work? And as you might guess, my reason for being a little bit skeptical is because we have seen how powerful the insurance lobby can be in the past. So is this really going to make a difference?
Randy, that has been a keen focus of ours, and it's where a lot of our advocacy comes into play. I want to first step back and go to March 2010, when the Affordable Care Act was enacted. 11 plus years ago, United Health's stock was trading at about $30 a share. Right now, we are trying to wake up patients, wake up organized medicine, whether it's state societies, specialty groups, and raise awareness around what is going on now with this law, the No Surprises Act, because the Department of Health and Human Services has significant leeway over how they're going to implement this law. Now, Congress has asked them to carry out their regulatory process to get this law ready. They have 1 year since passage of the law, so they have until December 27th of this year to promulgate their regulations. But the health insurance companies, Randy, are very hard at work, very quietly, trying to hijack this regulatory implementation process in their favor.
The only surprise to me about that is that they're being quiet. Next up in our list is Dr. Nicole Johnson, a very accomplished emergency room physician with experience in a wide variety of venues. She has some serious concerns about the misuse of mid-level providers. So let's hear what she had to say in episode number 48. So tell us, if you will, a little bit about what you're passionate about, what are the things that you think we need to fix, and some of the ideas about how we're going to fix it.
Well, the first thing I think we need to fix is we need to stop whining as doctors. We need to stop complaining. We really do.
Goodness.
There's so many things that are wrong. Part of it, it's our fault because we just let it go and we let it happen. Because we were busy taking care of our patients and we let other people start to manage healthcare. And so we need to, instead of sitting back and whining and complaining, we need to be solution oriented and organized and actually get things done. We need to get ourselves involved with legislation, with policy. And so this is how I got into it. I started on Facebook in a lot of physician groups. All I heard was just complaint. And I asked, is anybody doing anything? Why are we here complaining in this secret group on Facebook? And there were already a couple of grassroots organizations that were just starting to build. And so I started connecting with other physicians who were actually out doing things. And the area that really caught my eye and my concern was the story of a fellow physician who was misdiagnosed by someone who wasn't a physician, but claimed to have physician oversight. It was either a nurse practitioner or a physician assistant. And she was a resident at the time in a urology program. And she ended up having a disseminated fungal infection that was pretty much kind of blown off almost and completely misdiagnosed. And so this cost her her residency, and has affected her life completely.
Yeah.
And she started to look into this phenomenon that was going on around the country where nurses were lobbying to gain what they call full practice authority, which is basically unsupervised practice. And to us, it seems like that's medicine. At this point, you've crossed the line from, practicing advanced nursing to now you are practicing medicine in a way where there's no physician oversight. And we found that to be dangerous. Once she started coming out about this, a lot of people started flooding the feeds with stories of what is happening with their patients that were referred to them or patients they referred out who ended up seeing either a PA or not, or a nurse practitioner. And then people were seeing posts from nurse practitioners on social media asking for help with things that we thought were very basic things that a physician would know. And our alarm levels just continued to grow. Then we discovered that a portion of the Affordable Care Act was actually a driving force behind this growing phenomenon. It pushed for more non-physician practitioners to be able to serve independently from physicians in order to cover access for the expanding insurance covered population that the ACA afforded. So they didn't have a plan in that bill to increase the physician workforce. It was only the nursing non-physician workforce that was in that bill. And we started seeing the numbers of these online schools, quick turnover of nurse practitioner certificates, where from 2015 to 2016, those certificates doubled compared to previous years.
I had no idea the numbers were that profound.
Yes. And then in a wake of a nursing shortage and a physician access shortage, this was sort of it driving in every single state to legislate these types of nurses to actually provide medicine, or access to care outside of, physician supervision. And then then the AMA sort of started getting involved with it too. And they had a tracker and they looked at whatever the states that actually were allowing this to happen, where exactly were these nurses practicing? They were predominantly practicing in the exact same places where physicians were already practicing. They were not covering areas with low access, like the rural communities. So we were, all of that information combined with the danger of it to patients that got us active. And we started a few different groups. Now there's two, one a little larger than ours, but the two groups sort of have a different focus and how they interact. Our group, Physicians for Patients, or Physicians for the Protection of Patients, is the longer name. We focus on ways that we can improve the physician and increase the physician workforce. And the other group, focuses more on lobbying against the growing path to complete 50-state, legislated nurses practicing without supervision.
Hi, I'm Rhonda Crow, founder and CEO for MD Coaches. Here on RX for Success, we interview a lot of great medical professionals on how they grew their careers, how they overcame challenges, and how they handle day-to-day work. I really hope you're getting a lot of great information. But if you're looking for an answer to a specific problem, management or administration challenge, or if you're feeling just a bit burnt out, like maybe you chose the wrong career, well, then there's a faster way to get the help you need. No, it's not counseling, it's coaching. RX for Success is produced by MD Coaches, a team of physicians who have been where you are. I know you're used to going it alone, but you don't have to. Get the support you need today Visit us at mymdcoaches.com to schedule your complimentary consultation. Again, that's mymdcoaches.com, because you're not in this alone.
We'll get back to our interview in just a moment, but right now I want to tell you a little bit about Physician Outlook. If you haven't discovered this remarkable magazine, please do so very soon. It was created by physicians for physicians to showcase the intersection between clinical and non-clinical interests, whether it's writing, painting, cooking, politics, and dozens of other topics. Physician Outlook gives a physician perspective. It's available online and in print. It's really unique among physician lifestyle magazines. And like the Prescription for Success podcast, Physician Outlook amplifies the voice of any physician who has something to say. It also engages patients who still believe in physician-led, team-based care. And Prescription for Success listeners can get 3 months free when you enter our promo code RX for Success and select the monthly option at checkout. That's a really great deal on this stunning publication. And now let's get back to today's interview. In episode number 65, we return to another non-physician advocate for common sense in healthcare. As the co-founder and managing principal for Mitigate Partners, Carl Schuessler has got some really different ideas on how to fix the runaway cost of healthcare. And as you'll see, he is very passionate about what he does.
Our client, DeSoto Memorial Hospital, that you've heard about a little bit, bit about. They had a member during COVID. It was probably April of 20. They had a member that had all kinds of comorbidities, and they were going to have to be put in a long-term acute care hospital. Fair Cost has a direct contract. I don't know if you ever heard of Kindred Healthcare. Kindred Healthcare, they're the largest health tech. We have a direct, they liked what they heard one time when we were on stage up there against the Bucas, actually. They approached us, and they love what we were doing. So we've got a really strong contract, better than what you'll get on the other side with the Bucas. And so there was one of those facilities in St. Petersburg, Florida. The DeSoto Memorial is in Arcadia. So that's not a terrible haul, but a little bit of a haul. And this member wanted their wife there with them, but the wife couldn't go in the hospital, Dr. Cook, during COVID.
Sure. Yeah.
So here was the deal. I want you to hear this. This is really, really important for the listeners. Because of this team that we've created in the Fair Cost plan, Kindred got involved, and they said, our close facility is St. Pete. And the wife said, that just won't work for us. I want to be close so I can get there easy. So we found a facility in Sarasota, Florida, that they were able to go to. And we got them on the first floor with a window view of the parking lot so he could see his wife every day. It's like my dad says, son, having that doctor-patient relationship is like a panacea. It makes you feel good. It makes you feel like you're going to be okay because you have that relationship. That's obviously somewhat been lost, as you know, but that was so important. In this case, him seeing his wife was uplifting for him. It helped him get better. So how about that? We were able to go that far down the chain in care, and we're able to work out a single case agreement with that facility through our great network partner. And we did that. Then he got moved to and that, I guess you'd call that more of a SNF, skilled nursing facility. Sure. Then they got moved to a rehab center, and we were able to do a single case agreement there, same situation, first floor, and so forth. So those are just examples. You're not going to get that in a Buca.
I was just going to say, I don't, it's hard for me to visualize any insurance company that I've currently heard of going to that extent to help anybody. That's just amazing. Yeah, so you got to be proud of yourself.
I appreciate that, but I'm proud of our partners, and we're just so blessed. We did a big event at Gasparilla, the Gasparilla Inn, back in June. We had an Employer Day on June the 7th, and we had our Mitigate Fair Cost Day the next day. And I'm just proud to be associated with these partners. And Dr. Cook, if you had been there as a physician and the care you had for your patients, I know you did, you'd be blown away when you see the love come from the stage.
Oh,
the love these people have for the members and the dedication. If I showed you the amount of time and energy that pours into it for just the littlest things, and that in itself is different. And that's putting the patient back in the center of the system. Right now, the patients, if you imagine a solar system, they're Uranus. They're way out there. I mean, we got to get the patient back in the middle. And that's what our Fair Cost Health Plan really does.
Yeah, and I like your analogy to being way out in the solar system, but the idea that I get when I look at these scenarios that I've lived through before is it's much more than the patient being far, far away. The patient is looked at as overhead, and that's wrong.
Yeah, well, that's well said. I think it gets back to this, and this is something Barry Murphy and I coined, and we call it neighborhood health care. It gets back to the Marcus Welby MD days. That's where we need to go. And we feel basically neighborhood health care is neighbors taking care of neighbors. How do you do it? You have to eliminate the counterproductive communication barriers inherent in these traditional insurance employer health provider relationships. Mm-hmm. And it will lead to more effective and less costly outcomes for these plans and better benefits for the employees. And if the community-based model is done correctly, it enhances the hospitals, the local physicians, and the community pharmacists. Don't forget those folks. They've been getting crucified by the PBMs. For the audience, that's pharmacy benefit manager, but really my term is program bilking millions. That local care team is the difference. And that's what we have to get back to. So people, when we spoke at the Free Market Medical Association back in March and presented these 3 case studies, I said, do y'all picking up a common theme? I said, yeah, eliminate the middles. It's not that complicated, but you have to have a plan to build. And so, Dr. Cook, there's a great cartoon you may have seen. It's a doctor looking in the ear of the third party, the insurance company, and the insurance company's looking in the ear of the patient on the table. So it really is a great analogy of what's happened. And my dad told me that when managed care popped in the late 70s, early 80s, he said, it's it. So, and he was right. That's what we have to do. And so that's what we do. And that is what makes this so unique. And a lot of advisors or brokers or whatever you want to call them, don't call me a broker, by the way. That won't end well for anybody. We don't want you to get another wound when you're deer hunting.
We'll be careful.
Yeah, we don't want you to get wounded again. They're putting 1 or 2 solutions in and Band-Aids, and you have to build a plan where all the parts work together. And these partners that I'm so proud to be associated with have worked together for 6 years now. And they know when the others, needs to go tinkle. They know when the other has to burp. They know whatever that person has going on. They know each other that well. It's what you have to do here. And when they work in unison, it's a beautiful thing. And more importantly, it delivers better outcomes for the patients and the members and better financial outcomes for the patient, member, and for the employer.
Next up in our list of Season 3 highlights, we have Dr. Andrea Paul. In episode number 38, Andrea describes her remarkably astute observation that as medical students and residents, and even as licensed physicians, from time to time we endure a lot of examinations. She came up with a brilliant system to help us deal with that. So let's hear her speak a little bit about the beginning of Board Vital's exam prep system. So you helped me with the segue there. You were doing this in the morning, and in the evenings you were involved in some kind of an entrepreneurial project. And tell us what that was all about.
It was really spurred by my pathology program, in that the board prep for pathology, and my husband at the time was a psychiatry resident. So for both of us, we just had been talking about how, there are not a lot of online or electronic resources for board prep and even CME. And that was, a decade ago now. And so, how can we, what could be created that would make, the studying process just more efficient? I remember at the pathology program, there were, filing cabinets full of photocopied notes that the previous residents had written, and had been photocopied to almost, it was almost illegible. And I thought, wow, this is how we're studying. That doesn't seem efficient, doesn't seem like the best way to study, or, the best source of materials. Even like, how do you verify if this is what you need to know or not? So started working on, building out, taught myself to program enough to kind of build out a basic platform to start putting actual good vetted content, especially pathology. You need images. So putting that together in sort of a practice, it started as like a practice quiz, and then just having people use it and provide feedback. And then it kind of ended up adding also, psychiatry content, having that be a separate, sort of separate bank of questions. And then, people were pretty interested. It was getting shared. And then we started just charging a small amount just to cover, expanding it and hiring some additional writers to create content. Because up to that point, it was just me, using textbooks and whatever I could find to create content. So, and then, it kind of snowballed from there, I would say.
You make it sound, I don't want to say easy, because I'm sure it wasn't. It sounds to me like that must have taken a tremendous amount of determination to stay on that task long enough to put together something that really looked like a board examination. Was it grueling? Was it exhausting? What was it like?
No, so it's interesting. And I think that's how I knew it was the right thing for me to be doing, is because I felt like energized by it. I could have worked all night just building, and it was completely different than my experience with, few years of residency that I had done, where it was sort of something I had to do when I was, I felt like I was making myself show up and do that, versus when I was building something, of my own. I felt completely different. It was harder work in some ways, but it was more enjoyable for me.
Yeah, that makes a lot of sense to me. So that was the beginning of what would be Board Vitals, which I assume is still in business. And are you still a part of that business, or did you move it over to another owner? Where are we with Board Vitals at this point?
Yeah, no, Board Vitals, we started, it was late 2011, I guess technically early 2012, and it grew. I was there through growing it from me to two of us to 50 some employees and 60 different test banks in all different healthcare areas. So, PA, podiatry, dentistry, all the medical specialties, medical student exams. So it kind of really expanded to all of healthcare. And some of those areas became like their entire own departments, if you will. And so, it grew, and it still around, still growing, doing very well. We actually made the Inc. 500 in our fourth year, which was pretty exciting. And it was really, really fun, and really, just rewarding to see something I was working on a laptop in my little New York apartment turn into something, something that so many people use, which is really neat. And so it was acquired, and I stayed on for 2 years, and I'm still on as needed, sort of as a consultant and help with some things, but it basically runs independently now, and with an awesome team of 50-ish employees, and continuing to grow.
Well, for our final episode highlight today, we're featuring Dr. Saba Rizvi, a board-certified emergency room physician. When we last spoke with her, she had recently enrolled in law school with plans to become a more effective advocate for common sense in our healthcare system. In episode 62, she had a lot to say about how we're forced to use the wrong metrics to evaluate the quality of care in our emergency departments.
The other thing I noticed was the metrics, what I refer to as malignant metrics. These are guidelines that were put out by the American College of Emergency Physicians and the American Academy of Emergency Physicians as to how patients and what time frame patients should be seen in. For example, if your patient checks into the waiting room, typically depending on their complaint, you had a set amount of time before that they were triaged and seen. In this facility, every patient, no matter what their triage level was to be seen within 10 minutes. Not only that, you would have to put in orders within 15 minutes. And beyond that, you would have to come up with a disposition for the patient in about an hour to 20 minutes, an hour and 20 minutes. And then if you were going to discharge the patient, it had better be in an hour and 45 minutes or under. And these were not just loose guidelines. These were, you had to meet these metrics. You had to go by their standards.
And I'm gathering they were entirely arbitrary and they gave no consideration at all to the complexity of the workup or anything of that nature.
Entirely. Absolutely correct. Emergency medicine and medicine in general, it's not a factory. You can't dictate who's going to walk through your emergency room doors at any given time. And you can't dictate what their complaint will be or how complex that patient will be. And there are things that are outside of the realm of your control that are factors, rate limiting steps, how fast the CT scan is read by the radiologist, or the chest x-ray is taken by the technician. How many patients show up after that patient showed up, and what kind of complaints do they have, and what kind of remedies do they require, and treatments they require. It is absolutely chaos with some element of order to it. As anybody knows in an emergency department, you can't control your day, but yet the corporation and the corporates above want you to try to lasso that experience as much as they can into these finite and arbitrary timings, which really disadvantage not only yourself, but disadvantage your patients. That's the most important thing. They're setting you up for failure, but they're also setting those patients up for failure.
That's very well put. So what's your plan to get us out of this mess?
Well, I started to dig a little deeper and understand why I was being made to see patients within 10 minutes. For example, one night in particular, I had a very bad night. I was treating a patient, and it's just as clear as day in my head. I was treating a patient who was a bicyclist who had been hit by a car and had some severe lacerations to his face. I called the plastic surgeon who happened to be on call, and the guy refused to come in. So I had to sew this gentleman's face up as best as I could and have him follow up with the plastic surgeon the next day. And in this, he had other traumatic injuries that were being worked up at the time. Then I had a postpartum patient that was bleeding. I had a septic patient that I was taking care of and getting medications and drips hung on. And I also had a chest pain patient check in at the same time who most likely did end up having an MI. I have all these balls juggling in the air, as most ER physicians do at any given point in their shift. And for the most part, they're able to delineate tasks and to understand the triage levels and the severity of each of these patients and really work with the ones that are needing their attention the most and then work their way down. In this particular night, I was told that there were 3 or 4 more patients that had checked into the waiting room. So I asked the nurse, who was the charge nurse that night, I said, what are the complaints? And she rattled off, well, there's some person who rolled their ankle and somebody who's, got a stubbed toe and somebody else who's got a headache. It's had a headache for like a month. And I said, well, none of those complaints seem particularly, high acuity or that need to be immediately seen. I have some very sick patients that are going to be needing my attention. So let's let them wait a little while in the emergency room. I'll get to them when I do. And she said, no, that's not the way it works, Dr. Rizvi. You have to see them within 25 minutes. And if you let them sit for even 30 minutes, it's going to generate an automatic email to the CEO of the hospital. And I said, excuse me? And she goes, yes, because the ticker on the I-70 highway out there is going to read that the wait times are greater than 30 minutes. And the CEO won't like that. And so you'll be called in for that. And I said, well, so be it, because it's my medical license and the people that are needing my attention right now are needing my attention. And unless those people in the waiting room are deathly ill and need to come back right away, I'm going to give my full attention to the patients that need them right now, that need it right now. So the next day I was called in by my director and told that I can no longer do that. Can't ever.
By your physician director?
My physician director. Mm-hmm. That
Wow.
the CEO did get an email indeed, And the sister system generated the email automatically that the patient had sat there for about 25 to 30 minutes, and that I would need to speak with them and explain as to why I let that happen. They don't like to take any excuses. You have to understand, you're talking to people who either are physician administrators who have bought into the philosophy of the corporate non-physician administrators, or you're talking to administrators who don't have any clinical background to understand that you can't take your eyes off of the postpartum bleeding patient or the septic patient or the MI that just rolled in. And that an ankle injury can, wait. That's why we have a ESI triage level system. ESI level 1 and level 2 complaints get seen immediately because they are the highest acuity and they're the most dangerous, and they have immediate life or limb threatening emergency going on. And the level 3, 4s, and 5s are a little bit less, and there's a little bit more leeway of time. That's why we have that system. But to a corporate entity, each and every patient is not seen as an individual patient. It's seen as a dollar sign, and they don't want those dollar signs to walk out the emergency room waiting area.
So you were being evaluated not because of your clinical expertise. You were being evaluated on the basis of the scores that the hospital wanted to generate so they could say we're number one.
Absolutely. The scores and also the economics of it, right? So to them, they see it as purely a business. The more customers they can get through the door, the better it is for business. The more people they can herd in and herd out, clock in and clock out, the extraction of the dollars that they can, they're going to get from those patients. Now, if a patient sits there a little too long and decides they want to go to a different emergency room, or doesn't feel that their emergency is that big of an emergency at the end of the day and leaves the waiting room, then that's dollars and cents left on the table for them. And so the patient that's dying in the room be damned, you're not going to let any of those people in the waiting room walk out.
Thank you so much for listening today. We'll be back next week with our final episode of 2021 featuring more highlights from the past year. So please make plans to join us. We hope you'll visit our Patreon site where you can subscribe to the podcast, give us a rating, and hopefully offer suggestions on what you'd like to hear in future episodes. Thanks very much to Ryan Jones, who composed and performs our theme music. That's all we have for now, so please be sure and fill your prescription for success with my next episode.